Hello, thanks for dropping by to today's video where we're going to be looking at the Diabetes Mellitus Type 2. So Diabetes Mellitus Type 2, let's go over a quick definition here. So Diabetes Mellitus Type 2 is anytime a patient has either peripheral insulin resistance, meaning they're producing insulin, but the receptors and the muscle and the adipose tissue is not responding to it well. So the body's not responding to the insulin as it should. It's either suboptimal or it's not responding at all. The other pathogenesis could also be related to decreased secretion of insulin. So the body is secreting insulin, but not enough. So it's not enough to keep the glucose low, or normal, I should say. Let's go ahead and look at physiology, pretty much how insulin is secreted and synthesized. So when we're looking at physiology, the first thing we have to do is kind of look at histology of the islet cells of Langerhand, because it's within these kind of groups of cells where the insulin is secreted. So the islet cells of Langerhand, they kind of are organized in this round kind of configuration. And in the center of it, we have these cells. These cells are known as the beta cells. So in the center, we have the beta cells. These are the primary cells which secrete insulin. So of course, this is going to be our cells of interest. Now, surrounding the beta cells, there's going to be these other cells known as the alpha cells. And these alpha cells are secrete glucagon. And of course, glucagon is going to be the kind of known as anti-insulin, or you could think of it as it has the exact opposite effects of insulin. So since insulin will cause the glucose levels to go down, glucagon are going to try to maintain the glucose levels higher. Now, amongst the outer kind of peripheral cells, there's two other types of cells that I'm drawing here in orange and brown. One of them being the delta cells, which secrete somatostatin. And somatostatin, sometimes we call it the brakes. It'll inhibit both insulin and glucagon, as well as other hormones. But somatostatin is kind of like just stops all hormones, or most hormones that it comes in contact with. And then finally, we also have the PP cells, which secrete pancreatic polypeptide. So this is your general configuration of the islets of Langerhand. Now what we're going to do is we're going to take one of these beta cells here in the center, and we're going to go ahead and zoom in on it. And so we're going to look at what happens in the beta cell, which allows these insulin to be secreted. So first, in the periphery, we have this transporter known as the GLUT2 transporter. So the GLUT2 takes glucose from the serum into the cell, where it then gets acted upon by glucokinase. So once it gets acted upon by glucokinase, there's a series of events that occurs afterward, a long chain of events, glycolysis, Krebs cycle, all oxidative phosphorylation. Eventually, you're going to get ATP. Now, what does ATP do? Well, ATP acts upon another pump, which is known as the potassium ATP pump. This potassium ATP pump pumps potassium into the cell. So this pump is going to be inhibited by ATP. So ATP is going to go and it's going to inhibit this pump. So once this pump becomes inhibited, this will lead to an influx of calcium. So calcium is going to go in via another pump, and then this calcium is going to act on many different vesicles that I've drawn here. So this calcium goes ahead, acts upon all these vesicles, and within these vesicles you have these kind of insulin molecules, and you also have C-peptide, which we can get to a little bit, but you have these insulin molecules, and when calcium acts upon it, these vesicles go towards the cell membrane, they fuse with the membrane, and then they go ahead and secrete the insulin into the blood there. Now, a quick pharmacological connection here. Oral sulfonylureas and repaglinide are going to work by inhibiting this potassium ATP pump. So it's almost acting like the ATP, and that's why these are known as secretagogues, because again, once you inhibit this pump, you lead to the calcium influx, and then you're going to get release of insulin eventually. So this is a quick pharmacy connection. So this is about the secretion of insulin. Let's talk about how this insulin is synthesized, because this is known in detail. So how is insulin synthesized? Well, it's synthesized in the rough endoplasmic reticulum. We have a central protein known as C, and then it's flanked on both sides by A protein and B protein. Now these are further flanked by a pre and a post kind of protein section. And so this is the exact product that is produced when it comes out of the rough endoplasmic reticulum. And in this stage, this is known as the pre-proinsulin. So now, as it moves forward, within the rough endoplasmic reticulum, the pre and the post is removed. And once it's removed, you have this configuration. So you just have A, B, and C. This is known as proinsulin. So once you remove the pre and pro, it then becomes proinsulin. Now, what does proinsulin do? Proinsulin is going to then move on to the Golgi apparatus. So this is going to be your Golgi, that pancake look. So the proinsulin goes in through the Golgi apparatus, and then it goes within a vesicle that's formed within the Golgi apparatus. So in the Golgi apparatus, the C peptide begins to curve. So it curves around like that. And of course, on one side you have B, so the B is going to be right over here. And on the other side we have A, that's going to be placed right over here. So you have B, A, and C. Now, as you can see, B and A are right opposite of each other. So this B and A will then create bonds. And these bonds are going to be sulfide bonds, disulfide bonds. And once this bond is created, the C peptide is removed. And this vesicle, so this what you see here, this vesicle is eventually going to, so before we had the proinsulin, once the C is removed, this piece is called insulin. And then this vesicle is going to be the vesicle that I was talking about earlier over there. Of course, it's not going to be just one insulin, it's going to be more than one, but this is the vesicle that later gets acted upon by calcium to secrete insulin. Now, one thing that I want you to notice is you're producing two products. You have the AB insulin, the A peptide, B peptide, which is the actual insulin. Then you have the C peptide. And these two are created in equimolar amounts. So since you have an equimolar amount, and the C peptide is released into the serum along with insulin. And this is an important marker of endogenous insulin production. And this can be helpful in two scenarios. One is, say a patient comes in with hypoglycemia, and you check their insulin levels, it's high, and you check their C peptide, it's low. Well, that means that they've just injected themselves with insulin, feigning their symptoms. The second thing is, say for example, you have a patient with diabetes who's maybe taking insulin, and you want to see how much of their insulin is from their pancreas and how much is being injected. Well, you won't be able to tell because they both look pretty similar, but you can look at the C peptide. C peptide will tell you how much is being created by the pancreas, and the rest of the insulin that is not there is going to be the exogenous, the injected insulin that they were taking. So this C peptide is an important marker, and it comes up frequently on the boards. So that is the overall physiology. Now let's go ahead and take a look at some of the pathogenesis of diabetes mellitus type 2. Now, we know for sure that there's a genetic and environmental component to diabetes mellitus. And so what we'll do is we'll kind of look at both of those aspects of it. So first, let's take a look at genetics. So there are some genes that are that have been associated with diabetes, and these are called the mature onset diabetes of the young. And there's 5 of them. So we have mature onset diabetes of the young 1, 3, and 5. So let's talk about 1, 3, and 5. These are all going to be diseases where you have a mutation in the hepatic nuclear factor, hepatocyte nuclear factor. So in MODY1, it's going to be 4 alpha. In MODY2, it's going to be hepatocyte nuclear factor 1 alpha. And in MODY5, it's going to be hepatocyte nuclear factor 1 beta. So those are your 3 there. Now, there are 2 other genes, and it's pretty much the 2 missing, 1, 2, and 4. So MODY2 is going to be a glucokinase mutation. So you get a glucokinase mutation, and that increases the likelihood of diabetes type 2. And MODY4 is going to be a mutation in the insulin promoter factor, IPF1, which decreases your insulin release. So as you can see, these genetic syndromes are called mature onset diabetes of the young. And so this is important to differentiate when you get a young patient who has symptoms of diabetes, hyperglycemia. Sometimes it's difficult to see is it diabetes type 1 or mature onset diabetes of the young. And it's important to differentiate that because the treatment does change. Now, what are environmental influences? Well, Obesity, so of course, everything that comes with it, sedentary lifestyle, decreased exercise, is definitely one. And the current theory is when the obese patients have a lot of fat. When you have a lot of fat, that increases the release of certain cytokines known as adipokines. These adipokines are things such as leptin, adiponectin, TNF alpha, resistant. And what these all do is they increase the insulin resistance. And this makes sense because, of course, as you know, insulin will try to increase the amount of fat production in the body. And so, of course, if you're already obese, you want to, you want to try to stop making so much fat. So it makes sense that the body, in response to that, will try to decrease the reaction or the efficacy of insulin. So now let's go ahead and change our attention to the clinical aspect. So majority of these patients will be asymptomatic for a really long time until oftentimes they come with sometimes the complications of diabetes. And about 40% of patients will be asymptomatic and they get diagnosed on some sort of routine examination. If they do produce symptoms, the classic symptoms is going to be polyuria, polydipsia, and weight loss. So these are going to be your classic symptoms. And the polyuria, why does that occur? Well, generally when the serum glucose level is greater than 100 milligrams per deciliter, that will be greater than the renal threshold. And so what happens is then glucose starts getting dumped into the kidneys, into the urine, and then that's going to act like osmotic agent, which absorbs more water and prevents water reabsorption. And so then they have increased flow of urine. And so what happens when you lose a lot of urine? You begin to become hypovolemic, and that's going to increase the osmolality of your blood. And when you have increased osmolality of your blood, that triggers the thirst centers of your brain. And you get weight loss, and this is again because you're polyuria, you're losing a lot of water. And also one thing you should keep in mind is insulin is an anabolic hormone. So with low insulin or low response to insulin, then that you're going to lose your anabolic effect. So then all you have left is the catabolic hormones, and so there is going to be catabolism left over. Besides that, often patients will may present with blurred vision, and that this is an important point to bring up because patients with diabetes type 2, sometimes at presentation, they may already have retinopathy or they may already have nephropathy. And so this is why it's important that as soon as the patient is diagnosed with diabetes type 2, you right away, you start taking a look at their retina, you start taking a look at their albumin levels in the urine, and you start looking at the neuropathy. Whereas diabetes mellitus type 1, you don't tend to get that. It takes a little bit longer after diagnosis for these complications to occur. And also, especially with the female patients, they can present as vulvovaginitis. And this is because, one thing you should always keep in mind is diabetes is an immunosuppressed state. So since they're immunosuppressed, they're increased risk of these types of infections. Now, sometimes when patients are undiagnosed, or they're diagnosed but they're not monitoring their sugar levels well for whatever reason, they can get something known as hyperosmolar hyperglycemic state. And this is oftentimes abbreviated as HHS. There's also hyperosmotic oncotic state, and that's HONC, but this is the preferred way of writing it. So this is going to be in patients who have a glucose level greater than 600, so really high glucose level, and their osmolality is going to be greater than 330. So this is, of course, normally going to be less than 300. So this becomes an acute emergency. Now, there's another complication known as diabetic ketoacidosis. Now, this does tend to be seen more in diabetes type 1 patients, but 5 to 13% of type 2 patients may get this as well. So don't automatically rule this out, if you get the typical symptoms, but the patient has diabetes type 2 instead of diabetes type 1. But again, keep in mind, this is going to be more common in diabetes mellitus type 1. And for the sake of your boards, just DKA is diabetes mellitus type 1, and hyperosmolar hyperglycemic state is diabetes type 2. Unless they're really feeling evil, they're going to keep those like that. So let's go ahead and move on to diagnosis. The diagnostic criteria that I'm going to present here is based on the American Diabetes Association 2011 diagnostic criteria, and this is currently what's being used. Keep in mind this does change from time to time, so you want to keep up to date on this maybe, but again, when the changes are there, it's going to be minor changes, so they might change just a little bit. But do keep in mind that this is something you want to kind of look up from time to time. So when we're looking at the diagnosis here, one of the first things you want to look at is going to be the HbA1c. So if the HbA1c is ever greater than 6.5%, then these patients have diabetes. And so what I'm going to do is I'm going to make two columns, one for diabetes and then another one for pre-diabetes. So pre-diabetes are patients who are at increased risk for having diabetes. So these need an extra type of screening as well and monitoring as well. So if it's greater than 6.5% HbA1c at any time, that is diagnostic for diabetes. Now, if it's between 5.7 to 6.4%, then that's going to be considered pre-diabetes. The next is going to be fasting plasma glucose. Now, the fasting plasma glucose is basically the patient fasts for 8 hours. So generally, when they wake up, they just skip breakfast and they come straight to the clinic or the lab, and they go ahead and get their glucose checked. And if the glucose is greater than 126 milligrams per deciliter or 7 millimoles per liter, then that's going to be diagnostic of diabetes. Now, to be considered pre-diabetes, it's going to be between 100 to 125 or 5.6 to 6.9 millimolars. Now, oftentimes when they're discussing patients with pre-diabetes, if their fasting plasma glucose is off, they might call this impaired fasting glucose, and so IFG for short. Now, after the fasting plasma glucose, there's another test which is known as the oral glucose tolerance test. The oral glucose tolerance test is much more sensitive than the fasting plasma glucose, which means patients who may be negative here will turn up positive here. So this is more sensitive at detecting some of the more minor diabetes that patients may have. And so this test works by giving the patient 75 grams of glucose and then waiting about 2 hours and then checking their blood sugar level. Now, if after 2 hours their blood sugar level is greater than 200 milligrams per deciliter or 11.1 millimoles per liter, then you've diagnosed diabetes. And this is a general test that's done in pregnancy as well to test for gestational diabetes. And if to be considered a pre-diabetic, it's going to be 144 to 199 or 7.8 to 11.0. And then this is oftentimes also known as impaired glucose tolerance. So impaired glucose tolerance is referring to the oral glucose tolerance test, and impaired fasting glucose is going to be referring to the fasting plasma glucose. Now, you can also do a random plasma glucose. So this just means, the patient comes in, you don't do any fasting, nothing, you just check at any random time. Now, if this is greater than 200 milligrams per deciliter and greater than 11.1, then they're symptomatic. So this is important because if they're not symptomatic, it might just be that they just had lunch about 20 minutes ago. And so so these people tend to whenever you have lunch in about 20 minutes, it might go above 200. But if they have symptoms and it's greater than 200, then you've diagnosed diabetes. Now, in the pre-diabetes columns, these patients need to be monitored annually. So they need to be monitored more closely to see if they ever get into having the diabetes column. And some of them don't, and it may not progress, and some of them do. Now, the other thing is these patients are at a high risk for diabetes. So often you definitely want to start getting them on a diet and exercise regimen to prevent the onset of diabetes. And depending on other risk factors that they may have, you might even consider metformin. But this, again, is questionable. Some physicians do it and others don't. So it depends on what you feel is appropriate. Okay, so moving on from that, let's go on to screening patients. So in patients with diabetes mellitus, there's certain patients, because it is so common, there's certain situations where you want to screen a patient for diabetes mellitus, even though they may be asymptomatic. And so in adults, generally what you're doing is you wait till about the adult is greater than 45 years older. So if you have a patient who is above the age of 45, he has a BMI that's greater than 25, and greater than 23 if they're Asian, because Asians are at an increased risk. Plus, they have one of the following risk factors. So if they're over 45, high BMI, plus one of the following risk factors that I'll mention right now, then you want to go ahead and just screen them for diabetes. And what are the risk factors? So if they have a sedentary lifestyle, if they have a primary family history, so that's going to be someone in their family, brother, sister, father, mother. If they have hypertension, If their HDL is low, less than 35, or their LDL is high, greater than 250, if they have a history of cardiovascular disease, if they have some of the symptoms of insulin resistance, and these symptoms may be something like acanthosis nigricans. So this is kind of like a blackish discoloration in the knuckles or in the flexural areas, like in the armpits or back of the neck. PCOS is also a condition of insulin resistance, and this occurs with females. They'll have hirsutism and irregular menstruation. If the patient had gestational diabetes greater than and a baby with a greater than 9 pounds, PCOS again. Certain ethnicities, you definitely want to do them as well. These are going to be African American, Native American, Asian Americans, Pacific Islanders, and Latinos. So if you look at this list, sometimes I laugh at this because you pretty much have every continent except for Europe. So you have Africa, this is going to be, I guess, North America, this is Asia, the islands, and then this is going to be South America. So, maybe Australians and, Europeans. I mean, besides that, you're going to do it. So when you see this, you're usually going to be doing it because the risk factors are so general and so broad. Most people qualify one way or another. So children and adolescents, when do you want to go ahead and screen them? Because of course, as time is progressing, diabetes mellitus type 2 is coming up earlier and earlier ages. So generally, you don't want to start screening until they're 10 years old or puberty. Now, if they're overweight, so they're over 10 years old or they've already hit puberty, they're overweight, plus they have the following 2 risk factors. So if they have a primary or secondary relative, so this is going to include cousins, aunts, and uncles. If they gestational diabetes of their mother, so if their mother had gestational diabetes when they were pregnant with the child, if they showed the signs of insulin resistance such as acanthosis nigricans, and of course the ethnicity that I mentioned earlier, then you want to go ahead and even screen children for diabetes. So of course in children you need 2 of these. So maybe an ethnicity plus family history or something like that. You should definitely want to do it. So management. So how do you manage a patient with diabetes mellitus type 2? So, of course, the mainstay of management is going to be blood glucose. So you want to make sure you control the blood glucose. That tends to limit a lot of the complications and the severe symptoms that they may have. So when you have a patient, he gets diagnosed with diabetes mellitus, initial therapy is going to focus on diet and exercise, which I'll go through more detail in a little bit, plus metformin. So metformin is preferred because besides the renal failure and lactic acidosis, it relatively has low adverse effects, and the risk of hypoglycemia is low, which is very important because hypoglycemia can itself be life-threatening. So metformin is always used as a first-line management unless there's a contraindication. Renal failure is a primary contraindication, or if you give it and they get lactic acidosis, that's kind of like a secondary one. Okay, and so what you do is you start this off, and then what you do is you check their HbA1c, and if it's greater than 7% after 3 months, then that's considered kind of like a failure. So what you need to do is you need to step it up. So then you go into dual therapy. So we started off with metformin or another drug if they have contraindication. So what you do is you take the metformin and you add some of the other oral hypoglycemics. So this can be oral sulfonylureas, talazolidine diones, DPP-4 inhibitors, SGLT2, GLP-1, and basal insulin. So you can just give them basal insulin. So these are all the different types of oral sulfonylureas. You can choose which one is best depending on the various different types of comorbidities that they have, or what you feel will be best. So you go ahead and you give metformin plus one of these, and then you check the HbA1c in 3 months. And if it's greater than 7%, then again you consider that a failure. And then you go ahead and you go to triple therapy. So in triple therapy, you do the metformin plus the second drug that you were using. So whatever these second drugs. So what you do is you give metformin plus this drug and then another one of these drugs. So you give a total of 3 drugs. However, when you're mixing these drugs, you do want to watch for contraindications. So some of these drugs contraindicate each other. For example, insulin cannot be used with an oral sulfonylurea because of the risk of hypoglycemia. And then the GLP-1 cannot be used with DPP4 and the SGLT2 because they have similar, these obviously have similar mechanism of actions, and so these are just kind of things to keep in mind when you're adding, when you're doing the triple therapy. And if this doesn't work, then you go into more intensive type of insulin therapy, and then it kind of go up from there depending on how you want to do it. But so you can see that when you're dealing with diabetes type 2, you kind of have this stepwise progression, increasing the number of drugs depending on how their HbA1c level is. Now, what kind of diet is good? So the diet that is currently being pushed is going to be called the medical nutrition therapy, known as MNT. Now, this is a good solution because it's individualized. So, the patient sits down with a nutritionist and they look at 5 main factors to determine what's the best diet for them. So they look at the patient's activity level, so maybe what kind of job they're doing or how much activity they have. The carb consistency. So carb consistency is important. It's more important in type 1 diabetes where they're taking insulin, but here's important too. So carb consistency means how much you're eating at regular amount of carbs at regular intervals, and that helps kind of prescribe a consistent level of medication, so you don't have too much medication or not enough medication at any point in time. The calorie requirements for the patient, the nutrition of the patient, and the weight management. So if they need to lose weight, you want to take that into consideration. So by having individualized and tailored to every individual, that tends to have a more effective type of diet than just kind of using a blanket one for everybody. Now with exercise, generally you recommend children to be exercising at least 1 hour a day, whereas adults, they need to be doing at least 2.5 hours per week, and you want them to do resistance training for at least twice a week. And unless they have, of course, contraindications or something else that prevents them from doing resistance exercises or exercise in general, then you want to try to cope with it as much as possible. So this is going to be your blood glucose management here with diet and exercise. Now, the other thing that's important in patients with diabetes is you want to screen for complications. So there's a variety of complications that can develop, and you want to screen and treat these and these as soon as possible so that you can try to prevent the patient from getting these complications. The first complication that we're going to discuss that you need to screen for is going to be nephropathy. So what you do with nephropathy is you're going to check the urinary albumin. This is very important. This is the most sensitive test that you can do to check for diabetic nephropathy. You can also check for eGFR, but even though normally you're looking for low glomerular filtration rate, initially these patients will tend to have a higher filtration rate because of hyperfiltration. And so, but as there's more damage and they get into end-stage renal disease, the GFR will eventually go down. But hopefully they won't get to that. And when do you want to check it? Well, the first time you want to check it is at diagnosis. And again, oftentimes when the patient gets diagnosed with diabetes mellitus type 2, they may have had it for 7, 8 years, 10 years. And so by the time they get diagnosed, they already have renal symptoms. So you check it at diagnosis. If it's normal, then you just go ahead and you check it annually. And if it's, of course, if there's some problems or issues, then you're going to want to check it more frequently or you're going to want to start treatment. So generally, you do want to start treatment as soon as the urine albumin is greater than 30, and you want to start with an ACE inhibitor or an ARB, and those tend to be renal protective. Now, the other one is going to be retinopathy. Retinopathy is also a common complication with these patients, and so you want to, the way you check for that is, generally you want an ophthalmologist to do that with an eye exam. They check the fundoscope and they do a different test for macular edema and all that. And you want to do, again, you want to check the retinopathy at diagnosis, and then you can do it biannually and maybe even more frequently if there is some issues with the eyes. Next is going to be neuropathy. So neuropathy could either be peripheral or autonomic. So one of the common things that they'll do is you'll use a 10-gram monofilament to check for sensation in the arms and the legs, because it generally you have this glove and stock type of ascending neuropathy. And again, you want to do this at diagnosis and then annually from then on if everything is normal. Foot exam is very important because, of course, diabetes mellitus is the most common cause of amputations. So you want to check their feet every visit. So you're looking for like fissures, ulcer development, and all those on every visit. Now, of course, diabetic patients are at increased risk of cardiovascular disease, so you do want to do a cardiovascular assessment. So you want to check their blood pressure every visit, Make sure it's less than 140 over 90. And if it is high, if they say, for example, they have hypertension, the drug of choice in these patients is ACE inhibitor, ARB or ARBs, and that's just because, of course, it's beneficial for the neuropathy. So you're kind of taking care of the hypertension and you're preventing neuropathy as well. So you do that. And keep that in mind, very common question, USMLE question. You do check for dyslipidemia because of metabolic syndrome. You want to make sure the patient doesn't have that. You check for dyslipidemia at diagnosis and then 1 to 2 years after that. And if it's high, just start giving them a statin. You do want to give, in certain situations, you do want to give an aspirin as a primary prevention for MI. Men, you do it if they're greater than 50, women greater than 60 plus if they have one risk factor, such as smoking and a family history. So if someone is diabetic, greater than 50 or 60, and they smoke or have some family history or other risk factor, then you go ahead and start them with aspirin as a primary prevention. Of course, if they have a history of heart attack, then they're taking aspirin anyways, but that's secondary prevention. Also, again, remember, diabetes is an immunosuppressed state, so vaccinations are important. These populations of people definitely need to get the annual influenza shot. You want to make sure they get the pneumococcal vaccination, PPS 23, if they're younger than 65, PCV 13, if they're greater than 65, and if they're younger than 65 and they've already had the vaccine, you go ahead and give it again after the age of 65 with the PCV 13. And you want to make sure they get the hepatitis B vaccine if they're between the ages of 19 or up to 59, or if they have some other risk factor for hepatitis B, then you give it either earlier or later than that. So thanks for checking out this video on diabetes. Hope you guys learned a lot. See you guys in my future video. Bye.